Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins plastic and reconstructive surgeon, Dr. Chris Frost, will be speaking on understanding common hand conditions and when surgery is needed.
Great. Good afternoon, everyone. Thanks to Mark and Morag as well as Jess for setting this up. Excited to have the opportunity to talk to everyone today. So we're going to be talking about some common hand conditions and kind of how we think about them from a diagnostic standpoint up to treatment options, including surgery. No conflicts of interest to talk about. Just a little bit about myself, though. So I am a plastic surgeon here at Johns Hopkins. I focus primarily on hand and upper extremity surgery. I do have as a big part of my practice care of patients with complex extremity trauma, upper and lower extremity, and am one of the directors of the hand and arm transplant program, and then take care of a lot of patients with complex like amputations and things like that. But a big part of my practice is also taking care of kind of we call bread and butter hand surgery conditions, and that's going to be the focus of the talk here today. So one of the things that I think some people wonder right away is, well, what exactly do hand surgeons cover? And so I wanted to talk about that a little bit. And so this is going to vary a little bit surgeon to surgeon. And some people wonder, between orthopedics and plastic surgery, like sort of how things get divided up. And really, there's not a difference between an orthopedic hand surgeon and a plastic hand surgeon. This goes back to kind of historically to Sterling Bunau as a sort of father of hand surgery, who looked at all of the different structures that are in the hand in this very small space. And wondered, this is kind of around World War II, like, should we have an orthopedic surgeon and a plastic surgeon and a vascular surgeon and a neurosurgeon all working in the same space? Or may it be better to have one surgeon that kind of takes care of a lot of these problems and thinks about things holistically? And so that's kind of what a hand surgeon does. I myself cover really everything below the elbow and in both the pediatric and adult population. And so, one of the big things about hand surgery is it's very much about function. And so that comes down to a lot of different factors. For patients who have surgery, it's a factor of the surgeon. And then the rehab is really critical, and it's a huge part of our success in taking care of patients with hand surgery problems is working with our occupational therapists on postoperative recovery and rehab. And that really can't be overstated how important that is. So just to kind of go through the plan for today, and this should be about 30 minutes or so, talk about some of the most common reasons why patients come to see me in hand surgery clinics. So things like hand arthritis, thumb base arthritis, finger arthritis, as well as nerve compression syndromes, the most common of which are carpal tunnel and cubital tunnel syndrome. So we'll talk about those a little bit. And then issues related to tendons, sort of degenerative conditions, things like trigger finger, as well as something called de Quervain's. We'll talk about that a little bit. And then something called Dupuytren's contracture, which is also very common. And we'll spend a little time at the end talking about trauma and sort of how we think about trauma and like really when should you be seeing a hand surgeon, and then what sort of timeline in terms of when we want to see you. So let's start with hand arthritis. So this is really common. Almost everyone, as we get older, is going to have some degree of arthritis. The most common location is we call the DIP joints, and so those are the joints at the very end of the fingers. And then right below that are we call the PIP joints, or sort of the middle knuckles, and then these are called the MPs. And so the end of the finger, very common. And then the thumb base is another really common area. And that's really related to how much wear and tear the thumb base takes during our lives. You can imagine all the things we do with our hands, all of the force that goes into the thumb, and then really rest on this bone that's about the size of a sugar cube. And so that mechanical loading over the course of your life can often lead to arthritis. In most cases, we're going to start with a history, an exam, and some x-rays. Usually, we're going to start conservatively, splinting, hand therapy, and then we'll talk about things like steroid injections. And then for patients who don't respond to that, we'll move towards surgical options. In almost all cases, the reason why we're going to do surgery, or the thing that we're treating about arthritis, It's not the x-ray, it's the patient. And it's really the pain associated with that arthritis. That's what we're usually trying to fix. It's relatively uncommon for us to have a situation where someone has like instability or anything like that related to the arthritis, although that can happen. In general, we're trying to help with pain. And so this is a typical X-ray that we'll see. If you look at this is kind of looking like right on the we call the AP of the hand. And if we look at joints at the different levels of the hand, we should see kind of a space in between each bone. That's where there's cartilage and fluid that's cushioning the joint. And over the time, you can have this sort of bone-on-bone wear that can happen. You can see a lot of arthritis in this picture here. And so again, just to talk a little bit about thumb arthritis to start with, because it's so common, it takes a lot of wear and tear over our lives. And so we're going to ask about things that make this pain worse. A lot of times pinching and certain activities will with grip strength. And then on physical exam, we'll do something called a grind test where we try to put some pressure on that joint to see if that increases the pain. And then we talked about x-rays. And then we want to think about this condition in comparison to a lot of other conditions that cause pain in a very similar area. And this is why it can be important to see a hand specialist for something like this. Because if you look at this diagram, you can see that a lot of different conditions are causing pain in this area. A trigger thumb causes pain here. You can have de Quervain's, which is pain here. Say a scaphoid fracture is pain over here. And then just above that is the CMC joint. And so identifying exactly where the pain is coming from is really, of course, the key to proper management. And so in most cases, or really all cases, we're going to start with splinting and hand therapy. We use our hands for so much of our lives. And as a hand surgeon, really everything we do, a lot of it is about function. And so I really want my patients to do all the things that they want to do. I don't like restricting the activities or telling them they can't do things that they enjoy. So we want to sort of make your hands work for you, so to speak, from that standpoint. But a lot of times, some activity modifications, working with the hand therapist, they can figure out how can you do those activities that you enjoy, but in a way that's less painful for you. And then there's a number of different types of splints that we'll use. And then if those don't work, we'll talk about steroid injection. This can be effective short term. So this is putting a steroid directly into the CMC joint. And then we kind of see how much relief you get, how long does it last for. If you get a lot of benefit, if it lasts 12, 18 months, we'll do a second injection. Around 2 injections is where we start to kind of give a little bit of pause because some of the risks of steroid injections go up. And the risks that we think about primarily are skin discoloration. You can get a little divot at the area of the injection. And then we worry about the tendons that are around the injection site, and you can eventually get some wear and tear on those tendons. And so now, for patients who have gone through all of that, that's where we start talking about surgery. This is a typical splint that we'll use. And so what are the surgical options? Well, I would say there's a number of them. And the bottom line is they all actually work pretty well. So we have good operations for thumb arthritis. The thing is, the downside though, is it's a pretty long recovery time. So the traditional operation is something called a trapeziectomy and ligament reconstruction. We do this operation a lot. It's been around for a long time. It certainly works well, but we actually remove the bone at the base of the thumb called the trapezium. And then we stabilize the thumb with typically with a tendon. A lot of times I will use something called a suspension plasty, where we use a couple of bone anchors and a special type of rope essentially to suspend the thumb that lets me move patients a little bit more quickly after this operation. But it's a long recovery, 6 weeks in a splint, about 12 weeks of downtime, and really returning to work is dependent on kind of what you do and what you need to do with your hands, but it can really be up to about 20 weeks or so. One surgery that we've kind of helped pioneer here at Hopkins and studied quite a bit, which we're going to talk about in the next couple slides, is something called a CMC denervation. The idea here is we target kind of the specific wires going to the CMC joint, and then we selectively perform a neurectomy, or we cut those branches. So we don't affect sensation to the hand or to the rest of the thumb. It's really just the CMC joint itself that we target. Advantage of this is that you potentially have some earlier motion. We don't need to do a ton of splinting afterwards, typically just about 2 weeks, and then a faster return to work. You do have to have a stable joint though. So I mentioned most patients are dealing with thumb arthritis for pain. And so if you have instability though, you're not a good candidate for this operation. There's a number of other things that people talk about as well. Fusions, in Europe, it's common to do a joint replacement of that trapezium bone. We don't do that in the United States, although that may be coming in the future. We had an implant that was similar to that many, many years ago, and then we had some issues with. And so that's not commonly performed here in the US. And then some surgeons will take out a portion of the trapezium, so that bone that sits right below the thumb base, and then put a spacer in. So let's talk about denervation a little bit. So again, we use this analogy of imagine a power lines going to a house. And if you look at that house in the middle, we just selectively take out the power to that one house. So we leave the continuity of the nerve otherwise. So it's these small branches coming off of these larger nerves that are going specifically to the joint. That's what we target with a denervation. And so we have studied this quite a bit in a number of different studies. The biggest thing with denervation is we don't have as much long-term data as some of these other procedures. We did a prospective trial in 30 patients with kind of equivalent outcomes to that traditional trapeziectomy and ligament reconstruction operation at 2 years. But that's not 10, 20 years. We have data for 2 years and now some data that we'll publish at 5 years where patients are still doing pretty well. But that's the biggest unknown with denervation is how long is it going to last for? Now, that said, if you have recurrence of pain with a denervation, you can always do a secondary operation later on. It doesn't really affect your ability to do an additional operation down the road. So some other common types of arthritis are of we call small joint arthritis. So these are the knuckles at the end of your hand and these middle knuckles. And this is, again, very common. We use something called Hebern's nodes, where as we get older, a lot of us will have these kind of nodules at the top of our fingers here. And those are caused by arthritis. Sometimes you get cysts related to that called a mucus cyst, and sometimes we'll go after those. But in general, we treat these conservatively. It's difficult to kind of go after arthritis and, you've got 10 fingers and you've got, three, small joints in each finger. And so going after each single joint, you can imagine can be quite challenging. And so we'll usually do sort of, we'll consider steroid injections, splinting, non-surgical options. And this is as opposed to CMC arthritis is something where our operations have a little bit more downside than the CMC operations. So the traditional operation for this small joint arthritis is to fuse the joint. That very reliably will take care of pain, but you lose all the motion across that joint. A joint that doesn't move isn't painful, but that is associated with some decrease in function. We can do denervation in these other small joints. That is a relatively newer concept, and we don't have as much data for that, but that is something that we will consider. And then there are joint replacement options as well. We tend not to use these a lot, except for certain circumstances like rheumatoid arthritis, because long-term outcomes aren't necessarily better than with a fusion and has some downsides in terms of implants breaking and things like that. But sometimes we'll talk about those. So this is, again, an example of arthritis of the small joints of the hand on X-ray. And then we talked about this a little bit, but this is what that denervation procedure looks like. We make an incision on the back of the finger, and then we kind of work our way around. And we, again, thinking about the house, we sort of turn off the power just to that joint and separate that joint from the sort of surrounding nerves while keeping those larger nerves in continuity that are going to the end of the finger. This is what a fusion looks like. And at the end of the finger, we call the DIP joint. Fusion actually works pretty well. And it very reliably takes care of pain. And it's not associated with as much problems with function as fusing that we call the PIP joint, so then the next knuckle down. You can kind of see here an example of what that would look like in terms of, this patient can bring their hand all the way down to their palm, but they can't quite tuck it in all the way to called the distal palmar crease like they can with the other fingers. And so it can be quite functional, but again, is associated with some loss of motion. So now we're going to shift focus here, and we're going to talk about something else that's really common, and that's carpal tunnel syndrome. This is the most common type of nerve compression, and this is associated with numbness and tingling in our thumb, index, middle, and half of the ring finger. And if it gets severe, it can be associated with muscle wasting. And so we'll do different tests and physical exam maneuvers to try to decide if this is a carpal tunnel is what's going on. And then we'll often get something called a nerve conduction study to sort of really identify specifically if the carpal tunnel is the sort of the culprit and whether or not there's involvement of, say, higher up along the neck or anywhere else along the arm. It's important to, when someone has symptoms of nerve compression, that we identify specifically where that compression is occurring. And then here again, as long as the EMG and the symptoms aren't super severe, so meaning there's not like muscle wasting or signs of motor dysfunction, we'll usually start with night splinting. That will often help for quite some time. Over time, oftentimes the splinting won't work quite as well, and that's when we'll start talking about surgical options. And then steroid injections for carpal tunnel can be useful. I don't do a lot of these because it has a similar effect when we look at the literature to just putting a splint on, and there's no downside to wearing a splint. That said, it can be useful as a diagnostic test too. Sometimes we'll do it if we're not quite sure of the diagnosis. We can do a steroid injection, and if you get a ton of benefit from that, then we say, oh, you may be someone that could benefit from a carpal tunnel release surgery. So again, this is just showing what the carpal tunnel looks like. So you can imagine a box, and on three sides of that box are bone, and then on the top of it is what's called the transverse carpal ligament. So that's what we divide in a carpal tunnel surgery. Whether it's done, we call endoscopically or open, that's the structure we divide, and that creates more space for the median nerve, which has got a bunch of flexor tendons and other structures that run through this tight space where there's really no give or take because it's surrounded by bone on most of the sides. And again, that causes symptoms in typically these fingers. Sometimes patients will have symptoms in their forearm related to carpal tunnel syndrome, but if you have that, we gives us some pause and we think about exactly what the diagnosis is and making sure that we have the right diagnosis. This is what a carpal tunnel splint looks like. Just immobilizes the wrist and can be quite effective. Really like patients to wear this at night. One of the big things we look for is night symptoms. Those are often quite bothersome, and those are very indicative of carpal tunnel syndrome and often get better quite quickly after carpal tunnel release. So there's really two major approaches to doing a carpal tunnel release. One is an open release, which is reliable, it's time tested. And then you say newer technique, but really has been around for quite a long time, is an endoscopic release. I do most of my carpal tunnel releases endoscopically. What that means is I make a small incision in front of the carpal tunnel and I put a camera in that has a special blade on it, and I divide the carpal tunnel ligament, the transverse carpal ligament, from inside the wrist. When we look at long-term outcome data, patients do the same pretty much, whether they've had an open release or an endoscopic release. The endoscopic release at 3 months is the same. I find that early on, my patients who've had an endoscopic release are moving just a little bit faster, have just a little bit less tenderness than with the traditional surgery, although we still do a lot of open releases as well. And then anyone who has recurrent carpal tunnel syndrome will always get an open release from my standpoint. One thing to remember or to realize about carpal tunnel surgery is those like night symptoms, the tingling in the hand, that will often get better quite quickly. But some of the numbness can take 12 to 18 months to get better. Depending on if that nerve actually needs to regenerate through the carpal tunnel, it does so at about an inch a month. So even just going from here to the end of the finger, could be several months for that to get better. This is what an endoscopic release looks like kind of schematically. And so on the right, you can see what that special blade looks like. And so there's a camera there and we see that ligament, and then that blade comes up and then we divide the ligament. Now, if patients have had a carpal tunnel surgery before and they still have symptoms, really kind of look carefully at what's going on. We see a lot of patients who are in this sort of situation, and the big question is, number one, did we have the right diagnosis? So was this carpal tunnel syndrome? It could be a sign if you didn't get better after the carpal tunnel release that maybe it was something else was going on. You had something in your neck. And so we'll take a pause and kind of figure that out. But you can have recurrent carpal tunnel syndrome. And so if we've done that workup and we decide that yes, indeed, this has recurred, then we can consider revision carpal tunnel surgery. This is to do a carpal tunnel release again. So we do these open. There's a lot of scar tissue, and we want to be able to see everything really well. And then one thing that I will do in these cases is something called a hypothenar fat flap. And so the idea is we harvest some of the fat tissue from this side of the palm. We raise that as a flap attached to the ulnar artery, and we use it to kind of drape over the median nerve to cover it in tissue. So as it heals again, there's not quite the same recurrent scarring that there was there before. So now let's move and talk about the second most common nerve compression, which is something called cubital tunnel syndrome. So, if carpal tunnel is these fingers, cubital tunnel is your ring and small finger. Those are what is affected, as well as the ulnar nerve, which is the nerve responsible that gets compressed in cubital tunnel syndrome, also helps to coordinate your hand function. So patients with really severe cubital tunnel syndrome just feel like their hand doesn't work quite right. And so there are these kind of signs that we look for that show us that some of the muscles inside of the hand aren't working quite as well. And so that's one thing that we look for on exam. And then we'll do some provocative tests where we try to flex the elbow. A lot of people get this, we're all holding our phones these days, especially in bed. And so, most people, if you hold your hands flexed like this for long enough, you'll start getting numbness in those fingers. It's really when that's persistent or it's bothersome or you're waking up at night with it. That's where you really want to see a hand surgeon. We'll often get an EMG as well, sometimes an ultrasound to confirm the diagnosis. And then to start with splinting, what we do is we start with a splint that keeps the elbow straight because this is a problem that comes at the elbow. That's where the compression point is. And that will often help. And then if patients have recurrent symptoms or it's not getting better with that, then we'll talk about nerve decompression here as well. Similar recovery to carpal tunnel surgery, but takes a little bit longer in cubital tunnel syndrome. And then for more severe injuries, you remember we talked about it's got to regenerate and it does it at about an inch a month. While in cubital tunnel syndrome, you can imagine it could be a really long distance to get to the end of the hand. And so it can really take quite a long time to get full recovery. So this is what the cubital tunnel looks like. You can look at right at the elbow here and can see where that compression point is. Sometimes after we release the ulnar nerve, it becomes mobile, or even before we do the release, it will want to move over the elbow. And so in that case, we do something called a transposition, where we kind of permanently move the nerve in a different spot to prevent it from snapping over the corner of the elbow here. And also in revision cases, that's another thing that we'll do in order to help with recurrent cubital tunnel syndrome. So now let's shift focus again and talk about something that's also really common. It's called de Quervain's tenosynovitis. This is really common in new moms holding a baby all the time, causes a lot of pressure right here and can be quite painful. So this is a tendonitis where some of the tendons that go to the thumb go right over what we call the radial styloid. And there's a sheath around there, and that sheath can become swollen. And then just like trigger finger that we're going to talk about in a second, kind of creates this cycle of compression where the sheath makes the tendon more swollen and the tendon makes the sheath more swollen. And a lot of times, where most of the time we start with splinting, that will often help about 60 to 80% of the time, but it takes about 6 to 8 weeks. Oftentimes we'll incorporate some hand therapy as well with that. And then for patients who fail that, we'll try a steroid injection. Unlike injections for arthritis, injections for this can't actually cure this because this is an inflammatory problem. So rather than arthritis, a steroid doesn't fix the arthritis that's there. It can make it feel better temporarily. This may actually kind of break that cycle between the tendon and the sheath and can be effective. We don't like to repeat that injection more than 2 times though, because it can really cause some fat atrophy and skin discoloration if we do too many injections in this area. And then finally, we can do a relatively small surgical release for this as well. Relatively quick recovery, but of course we try some of these simpler things first. So this is what that de Quervain's looks like. You can see that right at the corner of the wrist here, those tendons going to the thumb, and how that can become inflamed. And again, of all the things we treat, patients with this are often pretty miserable when they come in to see us in clinic. And this is a gratifying thing to treat because we can really make patients better pretty quickly for this. And so trigger finger is a very similar thing, but it's just in some of the other fingers and our flexor tendons. And the idea is exactly the same. So we have a tendon which gets swollen for some reason, and we have sheaths that help keep those tendons close to the bone and helps them move, helps increase our hand function. But it's a tight space, and you can get this cycle of swelling between the tendon and the sheath. And we have a very similar treatment strategy as we do for de Quervain. So we can try splinting in hand therapy. Again, it takes about 6 to 8 weeks of splinting with the fingers straight to be helpful. A lot of times we'll do a steroid injection. And then for patients who fail that, then we talk about surgical options. Relatively small surgery can be done with patients wide awake. And so now we're going to kind of wrap up here and talk about one final really common hand condition. This is something called Dupuytren's contracture. And so the hand on this side of our palm, it is has a thick fascia, we call, that's right on top of the tendons, and it makes the skin on our palm, if you notice, is different than the skin elsewhere in our body. When we grip stuff, we need the palm skin to stay in place and allow us to grab things strongly. In this, if you kind of feel the skin on the back of your hand, it moves around. The skin on our palm, as well as the bottom of our feet, doesn't do that because of this fascial system. And so that helps with that, but it can become thickened for different reasons and cause something called a Dupuytren's contracture. So that's where the finger will get pulled into flexion and you won't be able to straighten the finger. And that can be either at, we call the MP joints, or it can be at the PIP joints. This is what that looks like. You can see on the milder end on the left, where we see it looks like we call a cord of tissue that's just starting to pull that ring finger forward a little bit. And then you can see on the right a more severe form where it's really significant at that point. So, in terms of treatment options, we will usually watch this until it gets to the point where you get over about 30 degrees of contracture on the MPs. And then any degree of contracture we call the PIPs, we'll usually want to do something for that. And the reason for that is this will tend to get a contraction. So we want to get all of our motion back after this. And so that's an important sort of consideration is, intervening before we get a contracture in the actual joint. Because once that happens, even if we release that tissue, may not necessarily be able to get the finger fully straight, at least not without quite a bit of hand therapy. There's a lot of different treatment options for this. I think the kind of general concept, though, is we can cut the thickened tissue. We can do this with a small surgical procedure where we divide that band and let the finger straighten. We can do it with a needle called a needle aponeurotomy. And then there's something called Xiaflex where we dissolve that tissue. In all of those cases, you're not actually removing the thickened tissue, you're just dividing it so the finger can straighten. And so you're still going to have that thickened tissue. Sometimes that's uncomfortable, but it does allow you to straighten the finger, and it's a relatively quick operation. What we will often do for this is something called a fasciectomy. So we're actually going to remove that thickened tissue. That has the lowest recurrence risk. It's a little bit of a bigger operation. You end up with a scar along the finger. But we like to get patients moving right away after this. So after surgery, we'll have you see a hand therapist as early as we can, just a couple days after surgery, and then we'll get you moving. And then finally, after surgery, we have you wear a splint at night to try to maintain the benefits that we have. But then otherwise, we really want you moving right away. And that's kind of the whole goal is getting you back to your function. And then, so I wanted to talk just a little bit about hand and wrist trauma. So this is another big part of what we do. And one of the big questions is like, well, when should you see a hand specialist about these injuries? And so what I would say in general, it's always better to err on the side of earlier, but There are quite a few things where we really do want to see patients within about a week. Now, of course, if you are in the ER with like an artery or a neurovascular issue, that may be something that we take care of emergently or urgently. But if you have, say, like a flexor tendon injury, we really want to see you within a week because that's something that it's very fixable, requires quite a bit of rehab afterwards. But it gets much harder if that time to seeing us and going to the OR to fix that flexor tendon is delayed by more than a few weeks. Similarly with fractures, we want to fix those when the bone is still mobile. It's a lot easier to do and a little bit of a quicker recovery versus if we need to kind of re-break the bone in order to get things moving again. And so with that, thanks so much for listening today. I'm happy to take any questions, just some references here, and then we'll get started with questions. All right, so I have two questions here. So I see, are there any risks with CMC arthritis surgical options, trapeziectomy or CMC denervation? Yeah, I think that's a great question. The number one is the recovery after these surgeries. We don't want to downplay that. There is some significant recovery. It's less so with a denervation, but that's why we'll want to try some of these more conservative things first. So the surgery works, but takes some time to recover. Now, in terms of a trapeziectomy or CMC denervation, really, we want to, some of the risks are number one, there's a lot of important nerves that run along there. It's not uncommon to have a little bit of pain or numbness after those operations because of the nerves that run past there. And then theoretically, it's possible to destabilize the thumb. So long term, sometimes patients with a trapeziectomy will start to get some subsidence where the thumb base will start to drift down a little bit. We don't tend to do anything for that unless it becomes symptomatic. And then that's when we'll talk about revision surgery, which definitely can be done. But I think in general, the operation works well, as we mentioned. And then another question here is, when do you know it's the right time for a patient to have surgery? That's like the key question that we're always thinking about whenever we see a patient for any issue. And so it's a balancing of risks and benefits and a conversation with the patient about what their goals are. So we want to think about function. We want to think about what as a patient are you trying to do that you're not able to do right now? And then how severe are your symptoms? And then we balance that against, well, what are the surgical options and what are the risks associated with them? So something like a carpal tunnel release, which is a relatively quick recovery, if you have significant carpal tunnel syndrome, uh, makes sense to maybe proceed a little bit more quickly with surgical release because we expect that you're going to do well, and we can make you feel better and sort of get you onto sort of what you want to do. But sometimes, if someone has really high demands, we may decide to do something earlier versus if someone is maybe has arthritis but isn't super symptomatic or is able to function well. We may wait. We may not do anything for those patients. And then so I have a question here. How long does return to work take after thumb arthritis procedure for someone who works at a desk and types? That's a great question. So let's talk about CMC denervation. I have patients in a splint for 2 weeks. That includes your thumb and your wrist. Some patients are able to type with that splint on and want to go back a little bit more quickly, but we typically estimate about 2 weeks. Now, if you're, say, in the healthcare field and you're taking care of patients, sometimes we'll wait a little bit longer than that because we want the incision to be healed up enough that we're not worried about, bacteria or things like that getting in there. But you usually can do desk type work relatively quickly. After trapeziectomy, in general, it's just a little bit more downtime, but still in a splint, a lot of patients can go back to typing and things like that after around 3 to 4 weeks or so. We'll often ask for a little bit more time from work than we think we may need, just in anticipation of being able to have that time so that you can take the time you need to recover. And then if you want to go back a little bit sooner and you're doing well and you come back and see me in clinic, then we'll talk about that. Another great question here about carpal tunnel syndrome. What advice do you have to prevent carpal tunnel syndrome? A lot of our day-to-day stuff that we do does increase symptoms associated with both carpal tunnel and cubital tunnel. So being mindful of breaks is important. If you are having carpal tunnel syndromes, thinking about your work setup can be really helpful. So having a pad for your wrists, making sure that you're not holding your hands in sort of a flex position like this. So really optimizing your positioning and you can tell if it's working based on whether or not your symptoms are getting worse or not. Now, that said, it's not necessarily the case that this causes carpal tunnel syndrome, though. It's also just a really common condition. Our workplaces make symptoms worse. You may get symptoms earlier, but it's also just something that's quite common. And then, what advice do you have to prevent hand and wrist injuries? Oh, that's we answered that one. Oh, for someone. Oh, that's okay. So we'll move on to the next one. So with thumb arthritis, as long as I can deal with pain, which can be pretty bad, am I doing harm to wait on surgery? Another really good question. The answer is no. So if you have thumb arthritis and you continue to live your life with that discomfort, your x-ray probably will get worse. But again, we're not treating an x-ray, we're treating a patient. And so it's really about the symptoms that you're having. And we don't try to tell patients to avoid activities as long as they're doing well. And we want you doing all those things that you enjoy. There's not really additional harm to waiting. This is kind of a surgery where maybe a carpal tunnel release we may want to do sooner to prevent some of these issues down the road of really severe carpal tunnel. But in hand arthritis, there's not really any disadvantage to waiting as long as we possibly can before considering surgery. And then I am 2 years post distal, I think, uh, distal fracture with ligament tear. No surgery was required, and I developed CRPS, which resolved quickly. No pain or symptoms, but I still cannot make a full fist of my left hand. Is it too late, though, to regain full function? Um, so this might be a distal radius fracture with ligament tear. After an injury like a distal radius fracture, it is not uncommon to lose a little bit of hand motion or wrist motion. We usually find that immediately after the injury to about 3 months, there's a lot of increased swelling and inflammation. We try to get patients moving as early as we can during that period. And then it'll often get better between 3 and 6 months. But it's also not uncommon to have some more persistent symptoms. And we really try to do hand therapy first to maximize what function we can get. And there's a lot that hand therapists do. Their tool basket for helping in this exact situation is really, really deep. And so what I would recommend is, come and see us and we can kind of get you working with hand therapy. And a lot of it depends on are we able to passively open your hands and move your wrist? Are you able to actively move? So when you activate your tendons, and we try to decide like where is the problem coming from. But if hand therapy doesn't work, there's a lot of surgical options as well that can be considered with a contracture release or something called a tenolysis where we free up the tendons as well. So this question is, I will be having a CMC arthroplasty with tendon transfer. What is the recovery period look like after that? Everyone's protocol is a little bit different after trapeziectomy and ligament reconstruction. In general, most protocols are going to have you in a splint, in my protocol, for 6 weeks. That's pretty strict. We don't do a ton of motion during that time. Although I mentioned sometimes I will do a suspension plasty, so kind of a special technique with anchors where I'll get you moving a little bit more quickly than that. But you're still in a splint for about 6 weeks, and then we start getting you moving with hand therapy. But total recovery, I typically say, is about 12 weeks or so. And then if you have a really high demand profession, like if you're a construction worker, maybe a little bit longer than that. So this is a question that says, what are your thoughts on silicone knuckles? What do your patients tell you about dexterity with these new knuckles? Yeah, so that is talking about different options for joint replacement, which we do have joint replacement options for the NP joints as well as the middle knuckles, again, the PIP joints. Um, I usually use these in the setting of rheumatoid arthritis. Patients can get a very sort of typical hand deformity from that, and we can really help them out quite a lot with arthroplasty in that case. So we remove the joints and replace them with these silicone spacers. In general, though, if we look at all types of arthritis, these silicone implants tend to break over time. And in terms of the range of motion that you get, you tend not to get a ton of increase in range of motion compared to some other more reliable techniques. And so for that reason, for osteoarthritis, I generally don't move towards those silicone arthroplasties, but in the right patient and for other reasons, like in rheumatoid arthritis, I think they can be certainly a good option. This is talking about, so we talked about de Quervain's in postpartum, which again is super common, but also about pregnancy and carpal tunnel syndrome. Yes, very common. It has to do with, many, many different factors, but I think largely there's a lot of increased swelling that patients who are pregnant have, an increase in fluid volume. And that carpal tunnel syndrome we will often get better after delivery, but it doesn't always. And there are some patients who have such severe symptoms in pregnancy that we do consider doing a carpal tunnel surgery while they're pregnant. And again, the surgery can be done with the patient wide awake. So we do just some local in the pre-op area. Surgery is pretty quick, but in general, we try to wait until after pregnancy, see if it's going to go away, and then kind of go from there. What is the best exercise to help with recovery after carpal tunnel surgery? My recommendation is just to move your hand. So I don't do any splinting after carpal tunnel surgery. You have a soft dressing, and I tell patients, even in the recovery area, I want them moving their fingers, opening and closing, and making a fist. That's really the best thing that you can do. Now, I don't want patients lifting a ton of weight. Not that they're going to necessarily hurt anything with the surgery, but it's just going to be uncomfortable to lift more than we say coffee cup weight bearing. Of course, knowing that coffee cups come in different sizes, but that's sort of a general general guideline that we have for people. And then after we see patients at 2 weeks, we'll see if they're able to pretty much move everything with full motion. Then we'll have them progress. If they're having a little bit of stiffness, then we'll think about doing some sessions with the hand therapist, and they can be really helpful in getting that motion back. And then what advice do you have to prevent hand and wrist injuries like carpal tunnel for people like me who work primarily in front of a desk computer typing? So again, I think the key is just thinking about your desk setup. I think taking breaks is important when possible, getting up and walking around. And then using a wrist pad, it can be helpful. Mice that avoid computer mice that avoid our hands sort of sitting in a flex position like this. This is really what you want to avoid. So one of the tests we do to see if you have carpal tunnel is we flex your wrist like this, and that usually will bring on carpal tunnel. So you can imagine anything that kind of prevents you from having that sort of a posture, just sort of a gentle extension of the wrist is what you want to maintain while you're working and typing. That's what you want to do to prevent carpal tunnel syndrome. Do pain relievers help with carpal tunnel syndrome? Um, the answer is that in general, no. There's not a huge role for say like Tylenol and Motrin for carpal tunnel syndrome. Every once in a while is okay, but really this is something again you kind of want to see a specialist to have evaluated. Now, the second part of this question is it common for pain to come and go sporadically? Yes, carpal tunnel, it's very common for pain to come and go, for it to be episodic. Patients will sometimes wake up at night with symptoms, which is often numbness in the fingers. Now, this mentions pain. Pain can definitely be a symptom of carpal tunnel syndrome. However, it's not as reliably treated with carpal tunnel surgery. So it might get better, but we can't guarantee it's going to get better like we can with some say like night symptoms or paresthesias or tingling in the fingers that can more reliably get better. And so what we'll do in the situation where someone's coming in with pain that we think may be carpal tunnel related is we'll really think about like, let's make sure this is carpal tunnel syndrome. Let's make sure there's not a tendonitis or other issue that's going on that's causing symptoms. And so that I think was the questions that we had. Again, I just want to thank Mark, Morag, and Jess for helping to set this up, and then thank everyone for all of your questions. Great discussion. It was good to see everyone, and thanks again. And hope everyone has a good afternoon.
This will conclude this afternoon's webinar. We apologize if we are not able to answer all questions, but if you would like to have your question answered, please feel free to email hopkinsseminars@jhmi.edu. We would like to thank Dr. Frost for presenting today, and thank you to everyone for joining us. A recording will be emailed to everyone within the next few days. If you are interested in scheduling an appointment, please call the number on your screen. Thank you.